Ben tabii farklı bir açıdan.
I have a different perspective. Yes, drugs are very effective, but drugs are ineffective in certain ways. Therefore, pharmacokinetics, pharmacodynamics, and pharmacological approaches are also important in this sense. I will talk about those now. Of course, basically, once the drugs go into the body, they go through different processes. And among those, we have absorption and metabolic effect and distribution within the body and elimination. When this is the case, we call the process pharmacokinetics. And when the drug has an effect on the bodies, pharmacodynamics becomes the name of the process. And both parts are controlled by the genes, and when it's single gene, pharmacokinetics becomes involved, and if multiple genes are involved, then pharmacogenomics is the name that we give to this process. And when you look at the normal development among children in pharmacokinetics, we see that this absorption it starts at the age of 1 or 2, but at the age of 5, basically, it is totally acquired and comes to the level of an adult. And the distribution in the body is affected by many factors like molecular size, ionization, and lipid features, and the fluid and protein binding within the body. Around age 5, the fluid amount in the body comes to the amount of an adult. In terms of protein binding, albumin is bound at the age of 1, but between 1 and 3, the other proteins come to the level of an adult. And on the other hand, the elimination takes place via kidney, so kidney is also very important. It is said to have developed at the age of 1, but the average age for this is actually 1 and 2. But mainly, the renal elimination of children is always faster when compared to that of adults. And when we look at the metabolism, we actually know that the basic organ is liver. Phase 1, phase 2 reaction drugs are involved. Phase 1 is usually the process where we have the cytochromes. Phase 2 is the process where we have the transferases. In order for the clearance of it is used at the second stage for the clearance of a drug, and plasmaesterases are also involved in this process. Methylphenidate elimination is what benefits from this specific role. In drug clearance, the most important share belongs to the cytochromes. The cytochromes are present in the body in certain amounts, but their role in metabolism might be kind of different. What is important here is cytochrome 2d6. It is seen less in the body, but its role in drug clearance is quite high. And the development of the cytochromes, I mean their role in developmental process, is really important. It usually starts right after birth. Some of them rise high until adolescence, and 1A2, the part that is related to clozapine, tends to decrease together with puberty, but 2D6 is stable after the age of 2. And 2D6 has a very important feature. Its genetic variability is highest, and cytochromes reach to the level of an adult approximately at the age of 2, and around the age of 2 and 3, the drug elimination can take place. Other than the cytochromes, gluculin transferases reach the adult level between 2 and 4, but other than those transferases and cytochromes, the other enzymes change. Their change with age is not something that we're very knowledgeable on. These enzymes go on developing, but on the other hand, their phenotypes we don't know whether the phenotypes are going to be different from that of an adult. What is affected by, what is affecting this? Of course, the genetic change, variability of the cytokines, the comorbidity, age, and the other drugs. So pharmacodynamically, this drugs causes certain effects on the body. When we look at the efficacy before and after the receptor, we see that it plays an important role in the physiological change. Serotonergic and noradrenergic system develop after this one develops to the adult level. Pharmacokinetics and pharmacodynamics are important, and the approaches cover certain components. Pharmacokinetics requires the mechanism in the liver and the metabolism that takes place in the liver, and then the drug blood level becomes important, and then its effect on the organs become important. Since this is controlled by the genes, pharmacogenetic approach can also be possible. When we look at the metabolism, we see that 2D6 play an important role among the drugs that we use for pediatric and adolescence period treatment. And these are inhibitors of certain enzymes. The pink sign means inhibition. And phenylidate is one of the drugs that we use a lot. They play an important role in their metabolism, but non-macrosomal esterase is the process where it plays the most important role. Atomoxetin's metabolism benefits from this function. 2D6 is important, and its genetic variability changes in a certain way, but how does this change really take place? The Africans, Ethiopian people, etc., have high metabolizing characters, whereas it is not the case for us, the Caucasians. The current approach is that the majority of our drugs are off-label. Late response is seen most of the time. Poor remission rates are there. The side effects are more, and we decide with the information that is supported with those trials. The patient comes to our center with certain symptoms. We look at the drugs and adverse effect probabilities and the price and psychosocial status of the family, and then within time we come up with algorithms. And some algorithms are formed in our body, and as our experience increases, certain drugs start to be used for certain diseases, and without even noticing, some of them suddenly become our first choice. And as a result of this, the same patient group is administered the same drug all the time. But if pharmacokinetics, pharmacodynamics, and pharmacogenetics are taken into consideration properly during our approaches, then the quality of our treatment might go up. What do we do in pharmacokinetic? When the patient comes to us, we look at different criteria, but recently it's not enough to look at those criteria anymore, because the majority of the patients do not respond. So developmental changes and pharmacokinetic changes and therapeutic drug monitorization tackled by us group yesterday become important in the process. And in pediatric and adolescent psychiatry, the cytochrome 450 genotyping becomes important. So in pharmacokinetics, we look at the genetic and environmental interaction. So some information about pharmacokinetics should be updated. When we update those, we see that there are certain differences between adolescents and children. Lithium has similar characteristics. Risperidone, when we look at risperidone, we see that risperidon's pharmacokinetics looks like that of the adults, but together with adolescents, risperidone concentration goes up, which means in adolescents, the drug has to be administered at a lower level at the baseline. It might be more effective then, and also it is more in amount in girls. And one of the newest trials show that risperidone and the metabolite amount can tell us whether the individual is a low metabolizing one or not. But risperidone, cytochrome 380 is also in charge of metabolizing, so the information cannot be very realistic. Olanzapine is also important. The plasma level in children is higher, so it also should be administered in a lower dose when compared to an adult. Its profile is close to that of quetiapine, and ziprasidone has a dose-dependent course. Haloperidol has differences among individuals, so dosing should be very careful in children. Low doses are effective on tics, and high doses are effective in psychosis. Chlorpromazine is lower in children when compared to that of adults in the blood. Therefore, we need higher doses. But since the therapeutic interval is narrower, we have to be very careful. Methylphenidate, let's review some of the information on that. Pharmacokinetic profile is very much similar to that of the adults, but the serum levels do not make a difference among the respondents and the non-respondents, according to some studies, but other studies suggest the contrary. There are parameters in it, like type D and type L. Type D is more. In the recent drugs introduced into the market, D form is more in content, and methylphenidate, if given pulsatively, it becomes more effective and yields better results. In preschool children, we see that those children have greater exposure than school age, so it has to be given in lower doses. And we see that similar bioavailability is seen in the long and short-acting ones. Patomoxetine have similar profiles. The linear progression is there. The dose increases and the level increases, but it might change between individuals, like haloperidol, so we have to be careful while administering it. And when compared to an adult, it is more effective in amounts which are lower. Coming to SSRIs, fluoxetine is 2 times higher in children than adolescents. Therefore, in prepubertal period, starting from a half dose might be useful. Smoking and its effect on serum concentration is also known, and serum concentration and SSRIs have nothing to do with clinical relationship. We know that there is no relationship between serum concentration and clinical outcome, and also side effects in sertraline, and it doesn't have much to do with the blood levels. But when we look at the blood levels, we see that it is more in children than adolescents, and the blood level in adults is higher, and in terms of side effects, the children and adolescents are more sensitive to sertraline. So the suggestion is that in prepubertal periods, twice daily should be the method to follow, but in adolescents, single dose per day, but higher doses are found to be more useful. Coming to fluvoxamine, it reaches a higher exposure in children pharmacokinetically, therefore it should start with lower dosages. In escitalopram, the adolescent study shows something very interesting. The same dosage gives lower results in adolescents, and when we look at pharmacokinetics, we see that until the age of 12 there is no problem, everything is similar, but then together with puberty, associated hormonal changes take place, and the pharmacokinetic variability is often 3-6-fold greater in children than in adults. After initial dose regimen, the subsequent doses must be individualized for patients. Therefore, TDM should be considered. Pharmacodynamically, what exactly are we doing? In the same way, If we think that the drug is effective, we consider many factors. Of course, we first listen to the history of the patient, but then we examine the area where the drug is supposed to have an effect on, and then we follow the changes that take place in the brain, and imaging methods are used in terms of treatment. And receptors are evaluated by pharmacogenetics. If the response is on a level of a single gene, pharmacogenetics. If it is on a level of multiple genes, pharmacogenomics is used as a method. And in children, especially in terms of side effects, low therapeutic response and intolerance, and the other side effects are usually due to CYP450. And the most frequently seen variation is that single base change. Pharmacokinetics, what does this provide to us? And drug exposure and response might be very important. Genotype-specific dosing, can we really do that? And what about the action mechanisms of drug action? This gives us information on this too. And the molecules targeted by the drug, whether they're polymorphic or not, is also answered by this method. While doing all those in the patient, actually the same prescription and same diagnosis might have different effects on the patients. What we're looking for is something which is not toxic but beneficial. But of course we have to look at the others. Is it enough to look at the genes only? No, it is not. Of course, environmental factors are involved, starting from the phase of protein synthesis. We ran out of time, so can we please wrap up? Okay, I'll be very fast then. So genetic testing, the benefit is limited for drug initiation. But since we don't have much of a knowledge on those, we do not use them a lot, and the information is very limited, so we don't use them a lot in our clinical practice. Cytochrome 450 genotyping, what is being discussed about that, and shall we reduce the amount of dropout if we do so, and can we optimize the medication and dosage? Is it cost effective? Is it prospective or retrospective? How should we determine it, or is it really unnecessary? Of course, atomoxetine is what is important to us. Atomoxetine is the normal method in the normal metabolizing person. It turns into active metabolites, but if CYP2D6 does not function well, it increases the plasma half-life 4-folds, plasma concentration increases 9-folds, and clearance obviously is 9-folds lower, so greater efficacy is seen, and at the same time more adverse effects are observed. And heart rate, diastolic pressure, appetite tremor, loss of appetite tremor might be the other side effects to be observed, but without knowing the genotyping, following the side effects cannot be enough. Slow metabolizers and fast metabolizers have a difference of 0.1 milligram per kilogram only. So systemic exposure is so low, but in slow metabolizers, after the treatment, after 9 weeks of treatment, atomoxetine exposure becomes higher, and when administered overdose, mild symptoms can be observed. And this makes us think that the low metabolizers show a good prognosis of atomoxetine. Therefore, in the evaluation of atomoxetine, genotyping is actually considered to be unnecessary. In pharmacogenetic testing, the drugs are subject to pharmacogenetic testing on a 10% basis. Are there any example tests? Yes, 2 approved by FDA. Bir 5 dakika lütfen. Only 5 minutes, please.
for 5 more minutes. I'm sorry. We're over already, and you're talking longer than your 15 minutes. Summarize, please.
Bu esterazlardaki bir mutasyon.
This is a mutation in the esterases and requires lower dosage. And we know that one for ADHD. There are many studies and trials regarding that. Some of them are related with high positive response, but generally speaking, when it is that, it doesn't give positive response, and some of them are not related at all. So that one and neurobiological effect on boys give different results. There are different EEG differences, and there are some cases where there is no difference. When we look at DRD4, dopamine 4, in other words, there is not a significant difference between having a DRD4 mutation or response to treatment, and there is no significant relation with DRD2, a very mild relation with DRD5. When we come to ADRA2A, it is especially related with children with ADHD. And when this GLL is there, it is related with the genetic response. And another enzyme is COMT. And there is inconsistent information and data regarding that. And about NET, partially it supports it to a significant extent, but it is also related with the number of the trials. We don't know if it has positive effect on treatment. When we come to serotonergic system, there is one last study which is related to that. However, the response is that it is not very much related. SNAP25, it gives different results in terms of treatment response, and the other genes like MAO, cholinergic BDNF, and neurotrophic factors, we see different results and combined. So these are the results for the genes separately, but what happens when they are combined? Especially for DRD4, and they are not very effective separately, but when they are combined, they may have negative effect on the response to treatment. One recent study shows that when there are two genes, there is a negative impact on treatment. In terms of side effects, with regard to dopamine, there are very different results. Some say that when there is a mutation related with dopamine, there are more side effects, and some say that there are not very significant side effects. So, in terms of SSRIs, there are different results. Too, for the SSRI group medications, but what draws my attention is that when we look at response to treatment, there is a group which uses SSRI for 2.8 years, and if serotonin transporter mutation is present in these children, they may have low bone density, and in a very recent study, different genes were studied. And what about the pharmacokinetic dosage? So the metabolites can be different. They can be active or inactive, and these studies do not have sample size and power, and the patients are usually on co-medications, and these are usually retrospective studies. In conclusion, we start at a low dosage and we gradually titrate to higher. The dosages required for therapeutic effects in children are often similar to those used in adults. We have to avoid the use of multiple drugs. Generally, it is recognized that the immature or still maturing brain is more sensitive to the effects of a given drug, and long-term implications are not clearly elucidated. And hepatic metabolism are, of course, we have to use different strategies, like mentioned in the first presentation with regard to the resistance of these medications. And when we look at the side effects in children, cognitive and behavioral side effects are more. When we look at the ADHD, these adrenergic 2A is in the foreground. And with regard to NET, there are many question marks. Just can you please wrap up just for the next presentation? It's over now. Thank you.